As chance would have it, I was walking around the streets of Edinburgh early this morning, trying to decide whether there was a definition of when the sun had come up or not. It was a bit hard to tell. But I was listening to a podcast of an interview with Bruce Springsteen, who some of you have heard of, a famous epidemiologist, by the editor of The New Yorker. And Bruce Springsteen said he'd just written an autobiography, and that there was a religious ritual when he was a child that his father would drink a six-pack of beer in the kitchen, and when he'd finished the sixth can of beer, he would then start abusing his son. And this classic alcohol-fueled adverse child experiences. And the interviewer said, "But you seem to do all right." He said, "Well, 2 psychiatrists, one who died during I mean, it took a lot to get over this. I mean, his way out. But that's the exception. Most people don't have a way out to become Bruce Springsteen. It's the rest just suffer in silence, and which is what you've been telling us. When you think about are questions insoluble, you think about the homeless, and you think, oh my gosh, it's so complicated, so difficult. Maybe there's nothing we can do. But my understanding, and that's what we're going to hear, is that Emma Williamson, in her day job, does not take the view that there's nothing we can do. By the way, I'm not talking about people's biographies, because I think you have them somewhere. So Emma and her colleagues in the Maudsley in South London start from the assumption that there's a great deal that you can do. And that's what we're going to hear about now. Thank you.
Hello everybody. So I work with a team of psychologists across Lambeth in London, working in partnership with third sector charity homeless organisation Thames and Lambeth Council. And we, since 2011, have been trialling pilot initiatives to see how we work with people that have got stuck in adverse cycles with social exclusion and health inequalities, to see how we work with this group that have been long neglected by services, labelled as non-engagers, and that they're not able to make use of what's available. But actually, I think that that's the services that aren't engaging, not the clients. And I think we need to think more creatively about understanding where someone's coming from and what their needs are when they're not able to make use of services, to then meet them where they're at. And I think this follows really nicely on from thinking about ACEs, actually, because if we're trying to work with adults and parents that have children, we need to think about what are the strategies and applications for engaging them. And I think there's lots of relevance in the work that we've been doing with our guys in Lambeth. So Stuart, A Life Backwards by Masters, he says, homelessness is not about having a home, it's about something being seriously effing wrong. And I think that's really crucial, that it's not just a housing situation that we're looking at here with this population. But homelessness is a vicious cycle. It's a repeated cycle where you see generations of individuals that have struggled to sustain stable, reliable accommodation and access support in a timely, appropriate way. The individuals that I work with, it's not uncommon for the women and the men actually to have 5, 8, 10 children taken into care, and repeatedly having pregnancies with more children being taken into care, and that those children are raised in the care system and having histories where they go on to unstable housing and major complex needs. So I think the adversity leads to homelessness, and then the homelessness in itself leads to the adversity, where we see that homelessness is an experience of it's traumatic in itself. So we see that there's high levels of complex trauma that lead to homelessness, and then the homelessness in itself is multiple re-experience of trauma. And I think that when we're thinking about issues of health inequality, in the Marmot Review, as quoted here, there is a social gradient where someone's social position, the poorer their health, and we've been hearing a lot about that this morning. And I think that we need to really be thinking who are in the lowest social positions, and that's often individuals that experience homelessness. So if we want to go for the hat trick of ACEs, I think this population are really going to be the winners here. That we see that 60 to 70% would meet a diagnosis of a personality difficulty, kind of chronic relational issues in sustaining and managing contact with individuals. So that's crucial when we're thinking about service delivery and design, because their core difficulty, if you've had lots of adverse early experiences, is that people are terrifying and that making use of services is terrifying. And we need to have that as our starting point. I think that's really crucial. So it'd be between 5 to 15% of the general population might meet a diagnosis of personality difficulty. I think these are underrepresented actually in the literature from my experience, but they would say that 50% would have ongoing chronic mental health difficulties on top of that. I'm a clinical psychologist, so I'm speaking a lot about the mental health needs, which I think are closely related to the physical health difficulties anyway. But you would see in the client group that I'm working with in our research, we're seeing 100% of individuals with serious mental health difficulties. The literature would say 53% might have alcohol problems. We're seeing 98% would have drug or alcohol problems, with 50% having both. 75% would have forensic histories as well, regular ongoing contact with the criminal justice system. And individuals would have layers of comorbidities in this population. I think that there's lots of issues with sampling and how we get data, and how if someone has a difficulty, relating and talking about their difficulties, their whole life is constructed around avoiding getting in touch with their problems, then how are we sampling and assessing the real need there? I think that there's an underrepresentation in the way the methodological data is gathered. They're 9 times more likely to commit suicide, 42% have. That's relevant to 1.5% in the general population. And the average life expectancy is 43 for women. So this is really the population that we've been talking about in the earlier 2 presentations. So the general average life expectancy currently is 81 in the UK, so major. And overrepresented histories of trauma. Obviously, the majority of the clients that we're working with would have complex trauma. So I think that's really important when we're linking to the last presentation about ACEs, how you go about getting that information, because I would say that these are underrepresented samples for the individuals that we're working with again. So how do you support people in disclosing? What can they manage and when? I think it's really important consideration. And multiple barriers to engaging with services. So the model that we've been using that I was going to talk to you today is a model of creating psychologically informed environments. This came out of the Royal College of Psychiatry's Enabling Environments Initiative in 2010. It was suggested that actually we really need to recognise the levels of emotional trauma that accompany and in many cases precede individuals becoming homeless. That we really need to start with that trauma, with the adversity, to think how we work with people, and that's the starting point for us to be able to think, not designing services to treat the symptom, but we need to be thinking about what's the origin, what's the psychological impact, and then how do we work with individuals. So in Lambeth, we began with a service need. There was a call for us to really be thinking about this level of complex trauma that this population have, that they're not engaging and making use of services, but that it was a suggestion that we need to be holding this in mind. But across the country, there was no specific model of how we do that. So in Lambeth, we began to design a service based on the needs analysis of the population, thinking about how we tackle this revolving door homelessness, and being guided by a government good practice document that was about meeting the psychological and emotional needs of the client group. So we began a partnership, trying to really bring health and housing and social care together to develop a model that was really integrated and bringing all of the complex needs together in one place. Just briefly, I wanted to touch on some of the psychological thinking that we used, which I think is really core in understanding why people struggle with homelessness, and this has been our foundation for working with individuals. So there's a lot of pressure to solve the solution, and I think there's a fantasy that a tenancy is going to be the solution to adversity. So if individuals have unstable housing, let's find housing, and a lot of focus is on getting accommodation. But actually what you find is that people aren't able to sustain that. They repeatedly gain accommodation and lose it. There's a repeated cycle, and that I've worked with many individuals also that have been given accommodations and are still rough sleeping, or they're desperate to get into a hostel, and as soon as they're in the hostel, they're back onto the street again. So it's a much more complex issue than just thinking about the building. I think a home is a very dangerous place. What does that mean to be trapped and encased when homes have been very traumatic for most of the individuals? I think that what we need to think about is it being a state of unhoused mind, that actually it's disturbance of relatedness. And I think this is really crucial when we think how to tackle it and how to stop these repeated cycles where more and more children go into the care systems, and that we're able to kind of stop this cycle there and think about how do we help people bear contact to gain support from services to try and change this vicious cycle. I won't spend too long going into these theories, but they're available in my handouts with references if people are interested. But I think one of the crucial things for me in understanding how we understand how someone can't make use of services despite multiple services repeatedly offering and going to great lengths to give someone support. Why is it still that people aren't able to take up and make use of these services? And actually, what we see is that there's a terror in care, there's a terror in proximity, that lots of individuals with complex trauma have spent their lives avoiding individuals. People are dangerous, contact is terrifying, and actually they can wrap themselves in a cocoon of drugs and alcohol or avoidance or aggression to avoid that contact, which is so threatening. And not only contact with others, but contact with themselves. So even if they can manage to bear and they don't find others so terrifying, actually getting in contact with support and opportunities means getting in contact with all the things inside them that they can't bear to know about. And I think that's really important when we think about how we design services to support individuals. I think we also need to think about our parallel processes in the system as well, and what we can't bear to get in contact with as professionals, and in terms of service structure and design. I think that there's an unending pool of need and deprivation there, and I think at a human level that can be very terrifying and overwhelming, and I think at a service level that can also be very terrifying and overwhelming. If you start to really tap into this need, how do you manage that? And I think that all sorts of dynamics can get set up in organisations where you repeatedly feel that it's the clients that are failing to make use of the services, but actually we're setting up a system where we're not able to flexibly and creatively make the needs. So people are labelled, they're too chaotic, they're unwell, they can't make use of services, they're discharged very readily, that actually it's not the system that's failing, it's the individual. And I think we need to think about our own human anxieties about dependency and contact, which I think underlie that. So a PI, or a psychologically informed environment, is suggested that if you simply ask in a unit, in an environment, wherever we're supporting individuals, ask any staff member why they were doing something. If they gave a response that's based on the psychological and emotional needs of the service user, rather than this or that health and safety policy or rules and regulations, actually that's a psychologically informed service. So I'm going to be talking about homeless hostels where people can live for 9, 12, 18 months, but actually I think this has broader applications to how do we make services psychologically informed? How do we respond when someone asks us why we're doing something, that's based on the needs of the individual, that it's psychologically informed and trauma informed? So just in terms of our particular model, we have a team of 5 NHS psychologists at different grades working in hostels across Lambeth for our current pilot, and we're just at the stage of looking to extend that. We're currently charitable trust funded, and that's very concerning in itself to think about how great pockets of pilot innovation happen and come and go, and actually how do we keep the learning and continue to think about what works and work with the preventative. I think that we need to be thinking about longer term interventions that help with people with stability. So we're working in 3 core hostels across Lambeth and looking at individuals at the most complex end with repeated histories of eviction and abandonment, high levels of drug and alcohol, as I was saying, that haven't been able to make use of services previously. Our psychological model, by having a really integrated partnership, I think this is crucial if we're thinking about people can't bear contact and the terror of going along and engaging, reaching out and expressing your need to engage with services. We are removing that need to reach out and express your need, to identify it and reach out for help. We're in the hostels, based full-time, available, flexible, familiar. We're a person first, so that we can slowly develop that relationship and it not be about you having to lead with your trauma, lead with your difficulties to get support. I'll talk about it on the next slide. So if you think about that difficulty bearing proximity, that actually lots of people's whole systems are designed for desperately needing care and attention, wanting that contact, but at the same time that being terrifying and overwhelming, that we have got a model where we're slowly increasing in proximity. And I think that this is really important in any services that we're delivering, that we can slowly establish trust and help people get more and more in contact with us and with themselves. So we start with the container. So we're creating an environment where everything can be psychologically informed, like that quote I had a moment ago, that it's not about health and safety and risk. So we have a shared leadership approach where we really work on how does our partnership organisations come together? How do we not feel claustrophobic and feel taken over or attacked by the partnership organisations? I think when organisations come together in partnership, that's really sophisticated partnership work that's needed for that to be effective. And I think with the kind of NHS 5-year forward view and more integration and partnership across agencies and sectors, we really need to be thinking in a psychologically informed way, how do we bring organisations together to do that in a healthy, integrated way? So we worked really hard in establishing our foundations of a strong partnership. So we're trying to form a relationship together. We kind of came together in an arranged marriage and had to get to know each other and not feel too intruded upon or left out, excluded, in all the parallel dynamics that we see in the client group. So we have a strong management, integrated management leadership approach where we have psychology and hostel management that think together on a daily basis about everything we do, from the building layout to the staff rotas to the support that the staff are given, to management to move in processes. So health are really getting involved in everyone's business that wasn't our business before, and thinking about you're focusing on housing and your aim is resettling, but how do we do that in a way that someone can sustain it? How do we do that differently? We then have the next level, so slowly increasing in our proximity. So we've got the environment container that's thinking and holding, managing risk in a way that's psychologically informed. We then have indirect interventions, so we work with the hostel staff team together. So the hostel staff and the psychology team are all trained in a similar approach to understanding the emotion regulation difficulties of the client group. We work together on joint consultations. We have weekly reflective practice meetings where we come together to think, how do we understand this person's difficulties and who has a sense of what we think is going to be effective for the individuals. We then develop guidelines so that everyone can respond in a consistent approach, and we trial them and see if that's going to be the most effective way to work with somebody. So that's the indirect work. We then have slightly closer proximity again. So the mental health professionals and the support staff are on site so that we can slowly engage people, have a cup of tea, I'm Emma first. I'm not a psychologist, Dr. Psycho in your white coat, don't look at me in the eyes. You know, that's the response I might get if I'm leading with my professional role. Actually, I'm just trying to have a cup of tea, getting to know someone. Things that you might think are everyday things, but actually if we think about them in a psychologically informed way, they're informed by this difficulty with bearing proximity. That we're walking the dog, we're gardening, but actually it's kind of psychology by the back door. How do we form a relationship, trust, let people get a little bit closer to services? And then people might go on to engage in direct psychology. So they might start with the art group. That might feel the therapeutic art. The art is a vehicle so that they can focus on the art, not themselves, and slowly move towards group or individual therapy. So we have all of this in the environment where individuals are living. So they might come for 1 week, not come back for 3 weeks, but we'll understand that as part of the ambivalent anxiety of getting into contact with services. I was just going to tell you briefly about Lucy. Lucy is a woman that came to live with us with severe domestic violence. She was a woman in her late 30s, severe alcohol dependence. She was drinking super cider and vodka, a 2-litre bottle of vodka, and a good few packs of super strength cider a day. She had a really severe history of emotional, sexual, physical abuse and neglect throughout childhood. She had seen domestic violence in her childhood home, been sexually abused by her father, been housed with another extended family member through social services, and then the abuse continued there with an uncle. So she really was not able to get away from really torturous early experiences. She then went on in teenage years to have some early pregnancies and have repeated cycles of relationships with individuals that were violent, and repeating this cycle. And when she came to us, she had 5 children, 1 that was in care and 4 that were living with her ex-partner she was fleeing from domestic violence for. So we were supporting her with a court case to try and help her gain custody of those children. So she was very concerned about their safety, but also really struggling with her own needs and heavily using alcohol. And she was definitely a live wire. So she arrived in the hostel, smashed the office window, broke the television because she wasn't happy with that people weren't letting her choose what she wanted to watch. The staff teams were rapidly terrified of her. You can watch whatever you want on television. You know, they really struggled to contain the box of fireworks that she kind of had inside her. It was really, really difficult. And that every time there was contact with the children, that was further escalating her difficulties and her anxieties and the loss around that. We brought her to a reflective practice to try and understand, how do we understand this whirlwind, what's going on for Lucy at the moment. And the team began to think about, actually there was a bit of a pattern, that what they could see is at times of shame, at times of control, at times when they were inadvertently at a lower level repeating experiences that she had had during domestic violence. That was a major trigger. Her emotional arousal would flip over and she would lose control in the hostel. So the team began to develop some guidelines to think, what do we do so that we're not easily triggering her shame and her loss of control? How do we help Lucy lead in situations? How do we help her feel in control? She had to meet with management and psychology because of the risk around her and her risk to others. She was also readily self-harming in public areas when she was becoming distressed. There was lots of calls of police and ambulance, which was a repeated cycle from other hostel placements and supported housing that she'd had that had broken down. The teams weren't able to support her. And so that it became clear that what she wanted to do was be a bit more in control. She really wanted some strategies where she could help manage her emotions. And through some very simple emotion regulation techniques, like her having a lemon as a stress ball, her having timeouts, breathing tools, strategies like that, she was able to gain enough control that she then felt she wanted to make use of services. But before this, she'd never wanted to ever talk to a psychologist, have any mental health support. She was using the alcohol to really block out any of her past experiences. But we didn't start with the trauma straight away. That wouldn't be what she could manage. But we were starting with how do we just keep you safe and calm and keep everyone else safe in the building. And that was the levels that we started on. She slowly increased in proximity. And over time, as she gained more control and she was able to get some support with trying to get custody and visitation with her children, her alcohol rapidly decreased because she was able to develop more control of her emotions, and that it became a cycle, a positive cycle, where she was able to further manage relationships, get more in touch and move on to engage in more therapeutic work. So we saw police and ambulance call reductions, self-harm reductions, and she was able to over a period of time, sustain her placement, which was crucial, and as a result, go on to detox and rehab. And is now sober and living independently. She's just about to start work. She's been volunteering for some period of time. And this is someone with decades of an inability to make use of services. But by the environment holding her, first of all, that allowed her to settle enough to bear to get in contact with other people and herself. Okay, so just before I finish, to briefly touch on some outcomes that we've had. This non-engaging population, we've seen 89% of them make ready use of the full level of psychological support in the hostels. So that's not okay for services to say that these individuals can't make use of services, and they won't, and they're not ready for formal mental health interventions. And we've got really high rates of planned appointment attendance. So this really chaotic client group that will come and won't come, actually, if the services are done in a slow, flexible way that helps people trust and get in contact, we find that they have a 75% attendance rate. And the 25% that are missing, a large amount of that as cancellations, where there was kind of a mental organisation enough to come, hold the support in mind and let us know if they can't come to appointments. And these are better scores than kind of mild to moderate presenting problems in IAPT, in GP services, for example, with this complex needs population. And we did initially see some differences in who would engage. So we found that male drinkers tended to more readily engage than women or polysubstance misusing individuals. But in our further expanded pilot, after 3 years, we've expanded the model and we've now got a female-only project and some adapted interventions for women. That's something that we're continuing to work on, because I think that there are unique subpopulations that we still need to think what's going to work for them and how do we continue to learn and adapt the models. And we're really getting some breakthrough with individuals with polysubstance misuse as well. Through adaptations to the model, such as some later working, some flexibility around that, some incentivised engagement, lots of opportunities for concrete care and praise. I think that's really important, is what does care represent? You turning up might represent care to one person, but actually some people need to physically see what care might look like to trust. So is that you doing something practical, you doing something concrete, you showing in a physical way that you care to start with. We've seen major improvements in health. It's interesting, in the presentation before you were talking about the reductions in GP engagement. Well, we're really pleased to see increases in GP engagement for this population with chronic health problems that don't go in a preventative way to make use of primary care services. So we saw a 300% increase in GP attendance, which was mirrored by a reduction in emergency service use, bed days, and psychiatric admissions. An increase in contact with addiction services and nursing. So they're all the really preventative stuff that we want to see going up. We had one chap that was going, I think in the 6 months before, so his height 64 times a month to A&E, on average 30 times a month, so 32, so over once a day sometimes he was going to A&E, and he was also had a lot of contact with the criminal justice system, a 6'5" guy, absolutely terrifying, been evicted from every hostel in the borough because he would present as very aggressive and challenging, or go in crisis having a heart attack to A&E. But we were able to think with the team actually that he's screaming because he's scared. He's threatening you because he's scared, actually. And that just by changing our understanding of aggression being because of terror, it really changed the staff team's intervention with him. So rather than saying, don't you shout at me, this is unacceptable behaviour, you're going to have to go out if you're being threatening, to say, what's wrong, why are you shouting? Just the very simple reformulation of how we understood his difficulties changed the intervention, allowed the aggression to come down. We then saw an increase in anxiety, so more presence of, I'm having a heart attack. We, with medical advice, were able to think these are panic attacks, work with relaxation strategies, and then we got the criminal justice system down, the emergency services went up, we then got the emergency services down through that, and we worked with A&E to share that guideline and understanding with A&E, and we did a bit of training with the GP practice. So thinking about how you work with the system, because people will kind of chaotically bounce around the system. You might see an improvement in the hostel, but then they're bouncing back out onto the streets. So how do we just kind of have that safety net, keep that thinking, that psychological thinking, and sharing it together? So when he goes to A&E, don't say, oh, it's lovely to see you, have a sandwich. Actually, that's really reinforcing the attendance at going to the A&E. How about you functionally think about, okay, we need to check, you're saying you're having symptoms of a heart attack, let's be very functional about this, but we really don't want to have to see you coming here, and then redirecting to the hostel support network or the GP practice who do the cheering and the clapping and it's lovely to see you and reinforce the attendance. So that's how we can kind of positively alter the behaviour through redirection. Yep, we're just coming to the end. So we did a snapshot sample of criminal justice contact. We saw a 51% reduction in all types of contact, prison stays, police contacts, court appearances, individuals coming off ASBOs. Major reductions in self-harm, alcohol use, big improvements in occupation, living, physical health. So by starting with people bearing to get in contact, we're able to see change across the broad range of people's presenting difficulties. And medium to large effect sizes on standard mental health outcome measures, and that's really important when you think about the severity of people's mental health. But in this day and age, you need to look at cost-benefit analysis as well as thinking about the mental health. So we were able to show the health economic savings as well as the mental health improvement. And I just think that this has much wider applications. I think we all need to be holding in mind individual psychological needs when we're designing and thinking about services from the beginning of life throughout. And these individuals that I'm working with are the parents of the children that are coming back through the system repeatedly. Okay, and it's a partnership, so there's lots of people to acknowledge as well. Thank you.
Two questions, but in fact you don't need to answer them. They're really reflections. One is how you sustain the enthusiasm and commitment dealing with these most difficult of clients. And the second is why someone hasn't cut your funding. Usually if something good's going on, they immediately cut the funding, but how you manage to continue. Yes. Yeah. But you don't need to answer that now. Thank you very much.
Thank you.